Good evening, ladies and gentlemen. It's now time for the last session of the 7th day of the biggest virtual implantology event of 2020. As I'm always been saying that usually last sessions are boring sessions when it comes to an actual conference. But ladies and gentlemen, in our conference, it's a little different because the last sessions are certainly the best sessions. And I say that because of the kind of lineup that we've been having since the last 6 days from this Power Pack arena of Virtual Dental Implant Expo. Ladies and gentlemen, today we have with us a very special speaker, a person who's very dear to me and who's very dear to team DentistChannel.Online. The first time I requested Dr. Johnson to present, he said, Ruben, not only will I present, but I will make sure that I am a part of your expo so that you are not alone, your team is not alone, you have got my back. And I think it's because of people like Dr. Johnson James and of course all the other well-wishers this expo is going on. And I don't think I can be more thankful to you, Dr. Johnson, and to your entire team, and to the wonderful lineup, and to the suggestions, recommendations, and to all the help, love, support you have been giving me and team DentistChannel.Online. Thank you, Dr. Johnson, from the bottom of my heart. Thank you for always being there for us. And I know that you will always be there for us. Ladies and gentlemen, we have with us, all of you all know him as the Zygoma guy in India, but still a short introduction is what I would love to do for our speaker, Dr. Johnson James. Dr. Johnson James is an implant surgeon, a professor, and an international certified mentor with 15 years of experience in advanced implantology, that is zygomatic, piezo surgery, and peri-implant regeneration. With a postgraduate degree in periodontology from the Ragas Dental College and Hospital, he is a practicing board-certified implant surgeon, an active fellow of the ICOI, and a key opinion leader at Norris Medical. He is also a director of the leading chain of dental hospitals in South India, and a professor, a consultant, and a key speaker in the field of advanced dentistry. He's had the good fortune to work with distinguished surgeons in India and abroad, and has learned a great deal about implantology. This has helped him to accomplish pioneering results in zygomatic implant surgeries, one of the advanced implant treatments for patients with highly atrophic maxilla. Ladies and gentlemen, Dr. Johnson has a lot of things in his resume, but I would like to cut short because the ultimate thing to today's session is the presentation. Without much further ado, presenting to you, Dr. Johnson James live.
Thank you, Ruben. And I must say, whatever help I extended to you was because of your enormous efforts to spread knowledge. It's no way easy to get such a big lineup and conduct a program and keeping only science in mind. So you have all our love and support. So with that and without much time, we will move on to our presentation. See, now I did your first presentation and we talked about my journey into pterygoids and zygomatic. And today my focus will be on just one protocol which we have developed and which are propagating and teaching, and it has worked wonders to change the way our students and our friends practice implantology, and it eliminates that margin of error to a great extent, right from single implants to pterygoid to zygomatic implantology. So that will be the key focus of today's lecture. And of course, I start all my lectures by giving thanks to my dad, who has always told that we should be unique in our steps we take and keep ourselves being trained so that we become to that level where we become good teachers. So I should thank my alumni, where I am attached to as a professor and vice principal now, Rajas Dental College, a beautiful institution in South Tamil Nadu, and my team at Implantology, which has always been behind me to these kind of presentations. Okay, so we'll be seeing the scientific principles behind the TikTok protocols and the surgical protocols we have to follow. And I'll just show you 3 situations where we can use these TikTok protocols and how it will change the way you practice. Initially, if you see the earlier presentations, it's all about parallelism and placing implants axially exactly to the next tooth, to the next implant, and a lot of stress was there on axial implantology. But as the concept of tilt evolved, the concept of cortical implantology evolved, we now place implants where there's a good housing of bone, and we have developed prosthetic protocols to adhere to these protocols of surgical protocols. And that is exactly why we have this TikTok implantology protocols now. Okay, so I'll tell you what TikTok is. Okay, TikTok stands for use of tall implants, and these implants are not on or side, it is in cortical bone. That means the apical end of these implants should end with cortical bone. So we have to identify the areas of cortical bone in the maxilla and the mandible, and design and use implants which engage this cortical bone. And then the next segment, the top segment, is about use of the tilted occlusal concepts, use of multi-units, use of the occlusal schemes, the mutually product occlusal schemes, which will help us in rehabilitating a single to a full mouth implant. I hope I am being audible. I see my screen getting stuck in between. I hope it is not interfering with the audience. Okay, so now we see over here a simple example of a single implant. Now, if you see this, it's a premolar. Okay, okay, it's a premolar, and normally we will be placing an implant measuring from the height of the sinus, from the sinus wall. Okay, and this is what we'll use. So normally you will be placing a 10 millimeter to a 11.5 millimeter implant, whereas using the tic-tac protocol with slight tilt, I have here engaged the nasal floor and the palatal floor, and I have placed a 16 millimeter implant, which is giving me good bicortical anchorage. This is exactly the precise point. So these protocols are not only in the single implant category, you can use in full mouth rehabilitation also, and also in single implant, and more importantly in single implants, because this is where I see a lot of people ending up with failures, implant failures after 2 or 3 years, whereas these kind of protocols will give us a good success rate. So we can use this where there is atrophic jaws, there is a lot of bone loss, okay, and we can develop protocols, surgical protocols, to achieve high primary stability in these kind of cases. It's like clockwork. So the surgical protocol, and you do process rehabilitation, and we can go for immediate loading. We can go for we can get very good primary stability because of bicortical anchorage. Yeah, and then because of by good primary stability, we have immediate loading concepts, and because of immediate loading concepts, it's going to make a great change in the way you practice implantology. It gives us good biomechanical advantages, good prosthetic advantages. You can play prosthetics when you follow these kind of protocols. So what you see over here is not a pre-operative patient, it's a post-operative patient. This patient is a good friend of mine, a doctor. And what you can see here, rehabilitation with the tic-tac protocols, immediate loading, immediate denture conversion, immediate temporization, and everything that gives him a good quality of life. And patients also convinces for treatment because you are giving them immediate teeth. So this can go from single teeth to full mouth rehab. Okay. So what does this tall in cortical mean? Because of this tall in cortical protocols, okay, we get good primary implant stability. And because of good primary stability, there's good osseointegration, and good osseointegration helps us in ensuring a long-term success. At the same time, we can also go for immediate loading, and immediate loading which is more predictable. All right, so this is a primary advantage of using tall implants engaging cortical bone. And now we know we don't a lot of, even from single implant full mouth rehabs, we do immediate loading, and a lot of research behind immediate loading. The classical protocol of waiting for 3 or 6 months is now done. Okay, a lot of us who are more into aggressive practice do not wait for 6 months to load a maxillary implant. Yes, we usually do it 1.5 months to 2 months sometimes, just to wait for the soft tissue remodeling to take place. And of course, the one important factor to be considered is the psychological considers patient. Do not do immediate loading in a patient who has gone to multiple clinics and they tell, and he's also comfortable with delayed loading. If they are okay delayed loading, go for it. Do not try to convince and force patients with immediate loading, because that patient is where you're going to get some difficulties. Yeah. So when you talk about cortical implantology, on the first surgical protocol of tic-tac protocols, so we have two things in mind. One is we have to design and develop our drilling protocols so that we engage the apical cortical bone, that is called cortical bone engagement. And we have to use implants which are designed for cortical engagement. Basically, the apical threads are more narrower, and these are the active threaded implants. You can see all these are, I am attached to this beautiful company called Norris Medical. These are tough implants. These are pterygoid, exclusive pterygoid implants. You can see that the taper at the apex. And these are cortical implants, again, designed for engaging the peripheral cortex and the apical cortex. So use implants which are designed for engaging cortical bone. So basically the aggressive implants. You can see here the entire range of implants, even the zygomatic implants. Again, the drilling protocol designed by Branagh himself was for 4-point cortical contact, which we'll see here. So and this is a beautiful diagram by Mesh. Okay, so when we engage cortical bone, when we engage the apical cortical, we are engaging the buttresses. So the maxilla is a force distribution unit. The mandible is a force absorption unit. So when we bite, the force gets dissipated along the trajectories of force, which you're going to see in the next slide, and mandible absorbs the force. So we have to design our implant apex to engage these trajectory of forces so that the force is dissipated to the skull or to the bone rather than getting concentrated at the crustal implant. Okay, you got my point. So when there's less force concentration at the crustal implant, there is less, that leads to zero bone loss concepts. Okay, no bone loss of the crest. Long-term success is ensured, good stability, everything comes into play. Okay, so here you can see, so this is the canine buttress, this is the zygomatic frontal buttress, this is the pterygoid buttress. So right from a single implant to your full mouth rehab, because then we have the nasal bone, nasal cortical over here. Okay, so you design your drilling protocol so that you engage the apical cortical bone. Okay, so that is how it works. Of course, the mandible, we have the entire lower, the border of the mandible is basal bone. We have the myelin ridge. So lower, we don't have to worry much. Even a axial placement of implant will help you in engaging these basal bone. So very beautiful slide here, and you will see precisely what I mean by this in the CBCD sections. So you can hear here is the nasal anchorage. You can see here apical perforation, and one thread extends into the nasal cortex. You can see here the pterygoid implant. You can see here the pterygoid implant. You can see here the perforating the outer pterygoid plate, and the one thread into the pterygoid plate, the nasal cortical anchorage. And here again you can see the zygomatic implant. Okay, and you can see the apical perforation engaging the outer cortical plate. So all these concepts, okay, right from basic implantology to zygomatic implantology, work on a concept of cortical implantology and with apical cortical engagement. That's our tall in cortical segment. Yeah. And if you have any doubts of what I'm saying, okay, I'm sure you would have easy access to the animal jaw. Yeah. And then if you have an hostile machine, take some 4 unused implants, 4 failed implants. Okay, place them of different companies. You can take, drill it into your jaw. Okay, place an implant axially, the goat jaw. Okay, the behind part, and then you drill one in tilted. You can see here we have engagement of the 2 cortices over here. Here only 1 cortices. Okay, and when we did this, we found ISQ level of maybe in this segment 40 to 50, whereas here we found 60 plus. Immediately, even when do drilling, you change it immediately. You'll see a rapid increase in the ISQ levels, which prove my point of using tall in cortical implants. Okay, so what happens? So immediate loading is possible because we have the primary stability more than 35 Newton per centimeter cube. Okay, so to get this good primary stability, we have to think of under preparation of the osteotomy. That's a 2-step down osteotomy. We can use osteoid densification using denser bursts. Again, cortical engagements. All this will help us into giving us good primary stability. If you see a OPG, how to determine where is the cortical bone, all that is white is cortical bone. You can see here the nasal spine, the nasal floor, the palatal floor, the floor of the sinus, okay, the basal bone, the crystal cortical, the zygomatic, the pterygoid, okay, all are areas of cortical engagement. You can see over here again the nasal floor, yeah, the nasal floor, the palatal bone. So when you develop drilling protocols, your surgical skills to get bicortical anchorage, and you apex of the implant engages the cortical plate, you will see a great difference in the feel you get when you place implants. Okay, so when we stick to the surgical protocols, and when it comes to prosthetics, okay, if it is 2 or more implants, always use splintered implants. Okay, go for screw retained processes which splint the implant together. Okay, with metal, so rigid processes, and make sure you have a passive fit All right. And when it comes to occlusal scheme, we use a mutually product occlusal. It's called a canine guided occlusion. All right. And use shallow guidance of maybe 2 millimeters. Okay. That's all you use, especially in full mouth rehabs. The shallow incisal guidance of 2 millimeters will help you to prevent excessive forces, especially the lateral exclusive forces on the implants. So this is the entire protocol for the TikTok protocols. So tall in cortical and the tilted occlusal concepts. Okay. And coming to the prosthetic loading, we have 3 levels of prosthetic loading. So I usually, even when I do a single implant also, I immediately temporize with the immediate chart side temporization using acrylic. Okay, you can use a denture conversion for a full mouth rehabs, and then take an impressions again. You can go for a screw retained process within 7 days, and your definitive process after 3 months. Some authors even suggest 1.5 months, 2 months also, but 3 months is a safe period for any tooth. Okay, so and here again we'll see the importance of your splintered implants. All right, because when these implants are splintered together, they play a great role in maintaining your marginal integrity of bone. Good. Of course, we should not forget about the use of multi-unit abutments, because these will compensate for the tilt when you do full mouth rehabs. But single implants and 2 implants, you won't need this. You can do a cast abutment. They'll give you a good implants, good process with passive fit. But when you think of full mouth rehabs, of course, we have to compensate for all the tilt using your transmucosal abutments or your multi-unit abutments. Okay, in Norris, we have right from straight to even 60 degrees, especially for the quad zygoma cases. So when we compensate for the tilt using these multi-units, now we are able to give a very passive fit of processes, all right, and that helps a lot. So here you can see exactly what I mean. You can see here a very shallow incisal guidance of 2 millimeters, okay, and again not a very steep canine guidance, all right. So this combination of and the cuspal guy in the cuspal slopes in the posterior is also of maximum of 1.5 millimeters. So when these combination of processes you give, even in the definitive processes, it helps a lot in preventing undue stresses of the crest. So it helps us in that. Okay, so with all these protocols, we can treat more patients. Okay, your chat side time becomes lesser, your waiting period becomes lesser. Patients immediately agree to your treatment protocol, right? So imagine a patient comes to you and say, we'll place implant. You come after 3 months, come after 6 months for processes, whereas you tell the same patient, I'll give you teeth in 3 days. So the patient immediately agrees to your treatment plan. He would have gone to 5-6 clinics and he likes your treatment protocol. Okay, we don't have to go for extensive grafting, and a lot of those cases we don't have to wait. And at the end, what all this leads to is lesser and lesser time between implant placement and prosthetic loading. This is your USP. This is going to be a game changer in your implant practice when you change your conventional loading protocols to the TikTok protocols, the immediate loading protocols. So this is really going to be a game changer in the way you practice implantology. So TikTok also, it means time. We save time. So this entire package is beautiful package. Of course, we'll be taking more classes for you on how these TikTok protocols work, and I'll share the literature on these things. Good. So with that, we have done the scientific part. So I'll show you a couple of cases. I'll just have time for that. Maybe 2 or 3 cases where you use these protocols in single implant, full mouth rehab, and in segmental rehabilitation also. Okay, so here we have a single premolar, okay, a maxillary single premolar. You can see the X at the end, all right? So we need a crown for the molar also. So I have raised a flap because I need to show the, because you can see a deficient ridge over here. Yeah, so I didn't go for any grafting. So what I can see my angulation is not straight, it's tilted, right? So we tilt it to place the length of implant I've used is 3.75 into 18, right? So it has to go all the way to the nasal cortex over here. So you can see my implant placed. See, I did not place it like this. Yeah, here if I would have placed implant of maximum 1.5 millimeters. Whereas because of the tilt, and I should be sure that this is not touching the premolar root. Okay, because of tilt, I used to use a long implant. That means the tall implant. Okay, tall implant which goes all the way to the nasal floor, right? Okay, so to see the tilt I have used, this is my paralleling pin. This is a 30-degree paralleling pin. Okay, you can see how amount of tilt. So this is the implant placed, and I can see the tilt, which gives me parallelism. Yeah. So after the soft tissue remodeling is done, I just do a closed straight transfer. Okay, this is a closed straight transfer, and we have a castable abutment created, and we load on these zirconia crowns. So this is a soft tissue collar, beautiful soft tissue collar, and this is the end case you can see over here. One second, just move my slide here. So this is the zirconia crowns on the implant and the tooth, and that is the finished case. A happy patient is a doctor, a well-wisher. You can see the finished case over here, and this was done in 1.5 months. So I didn't have to wait. Sorry, this is done in 3 weeks only. I had to wait for the soft tissue collar to form. I didn't wait for the integration and all those things, because I have engaged. I have bicortical anchorage over here. So this is a loading done in 3 weeks using the tic-tac protocols in a single implant. I'll also show you quickly how we can do this in a common scenario where you would have normally go for sinus lifts and wait for 6 months to place the implant and then wait for 6 months to load, whereas how we have finished the case in a matter of 1.5 months. Okay, so bilateral segmental rehabilitation. Okay, the patient has only canine on one side and premolar on the other side. You can see a good amount of bone loss. Okay, even a sinus lift will be difficult because this is the sinus floor. Sorry. Okay, this is the sinus flow. You can see there's bone loss all the way here. If we place an implant over here, it will be practically impossible. Okay, so now here, what we're going to make use of is the nasal cortical, the pterygoid implant over here, and this is my plan for this case, right? So this case I had showed also in my first presentation, but there we talked about different protocols. Okay, so this is my drilling. This is my pterygoid implant. So we have an exclusive pterygoid implant in Norris called the Pterifit, which I use a lot. So we're not seeing about drilling protocols, just about the tic-tac protocols. So we place a pterygoid implant with very good primary stability of 55. Okay, and the anteriorly also we place that the tough implant, and you can see the tilt again to engage the nasal cortical. So you can see the length we used here, 3.15 into 18. And then we are using the multi-unit abutments to compensate for the tilt and convert the platform to the tissue level platform. Okay, healing cap, little bit of grafting. To the right side also we use pterygoid implants, tuberosity implants actually. Okay, so here we just give healing caps for soft tissue formation. Then impression maybe after a month's time. Yeah, good. So here we are done with multi-units. Here we can do conventional platform. So we connect the transfers, we take the impression, check for a fit of the transfers, splinted transfers, good. And that is the screw retained ceramic processes. Both segments good screwed in with good primary stability, sorry, good secondary stability, good. So that is the final process we have. Okay, and you can see here nasal implants in the anterior and posterior pterygoid implants. And you can see in this diagram, we have, this is a tuberous implant, and here is a true pterygoid implant where we have perforated the outer cortical plate, and that gives me a good primary anchorage. Here you can see the implant again on the nasal floor. Yeah, and here the pterygoid implant. So this video, if you have time for the video, yeah, will show you you can see here the perfect on the cortical plate and the implant engaging the outer cortical plate of the pterygoid. Okay. Here also you can see here the nasal flow. So all these implants placement we drill, we get a minor perforation, and then we go for implant placement. Good. You can see here also. Okay. So this is a CBCT rendering where we can again see the cortical engagement. You can see here. Yeah. You can see. So that's how a pterygoid implant is placed, and segmental rehab using pterygoid and nasalis implants. Okay. That's nice. So I'll come to my final case where we have done a full mouth rehab using tic-tac protocols. It's called all on 10. That's we are doing a lot of lectures on all on 10. We use 6 implants in the maxilla and 4 implants in the mandible. The 6 implants in the maxilla can be your all-on 4 with a pterygoid, or it can be an all-on 4 with one single zygoma. It can be a quad zygoma with pterygoids. So we have different combinations of that. Those things I showed you in my first lecture on Monday. The indications for zygomatic implants and pterygoid implants and various configurations which we can use in those cases. Lower, of course, a conventional all-on 4 is more than enough to manage cases. So this is a guided case. Okay, I'll show you the pterygoid segment, the anterior segment, the lower all-on 4, the pterygoid segment, and zygomatic segment in 3 segments. All right. So lower we are done a guided. This is the upper preoperative. This is the lower preoperative. Okay, this is lower. This is upper. So the lower ridge we are done totally flapless. Okay. So this is all the drills I'll be needing, a pilot drill and a 2 to 2.8 millimeter drill. So the guide in place. Okay, positional guides only, not the completed guided. I don't use the completed guided segment because I still like to have my feel of the drilling and the positioning rather than totally rely on guides. Of course, now we have very beautiful, completely guided kits and systems available. Yeah, so we have. See, lower we don't need to use actually very long implants because I told you the lower total border is basal bone and very good cortical. So engaging the basal bone is more than enough rather than having an outer cortical perforation. Never think of lingual engagement because we wouldn't want to risk perforating the lingual cortical plate on reach the lingual artery. If at all you're looking at cortical perforation, think of a buccal cortical perforation. Okay, so that's our implant and drilling done. Implant placed with good primary stability. That's a totally flapless procedure. And we rehabilitate them with multi-units. So 30 degrees posteriorly, anteriorly, I use 17 degrees, if not straight multi-units. So these two are 30. And you can see the parallelism between the implants. A deviation of 5 to 10 degrees is okay because this is going to be a milled titanium bar. So these things won't matter. So this is our lower segment done. Okay, this is the nerve and we are clear. So lower all-on 4, again, cortical implantology. Upper. Okay, I think this is a video. So you can see here. Okay, you can see here good placement, very clear of the mental foramen. As much of anterior posterior spread possible. Okay. That's done. So maxilla, we have a combination of the nasalis implant, the pterygoid implant, and the zygomatic implant, and again guided. This is a partially guided system. Okay, so minimally invasive flap we have raised. We first do one segment, right, and we screw in the. Okay, we don't need that. Okay, and then I'll just show you drilling into the pterygoid plate and why this video is important. Okay. See, I have kept my finger over here because once my drill reaches the pterygoid plate, it will get stuck over there. The apical, the crestal alveolar bone, it will run easily because it is drills. But once you reach the crest, you have to give a small push, and then only they will perforate the outer cortical plate. Okay, good. And that is the implant placement. So that's the pterygoid implant. Pterygoid implants and zygomatic implants are best examples of how cortical implantology will change the way you practice. So you can, as you place, when you engage the outer cortical, you will see the good amount of stability. You can feel it in your hands, how you can, the stability you get when placing pterygoids. Good. So again, this is the implants we placed. See the length, it's 4.2 into 20 millimeters. This kind of length, most implantologists, I'm not saying, of course, those who do a lot of full mouth rehabs will know this kind of lengths, but in the early stage, you never even thought such length of implants can be placed. Okay, so this is how I measure. So when I drill, I see the apical fall, and then I measure what amount of drill has gone in, and that is how we measure what length we need. So these are multi-units. So any offset in the multi-units can be adjusted by rotating in the implant head a little bit. So one segment done, then the right segment, same, pterygoid drill. Yeah, implant placed. So this is my zygoma, this is my nasal, and this is my pterygoid. So a slight offset of the multi-unit. So I rotated the pterygoid a little bit to adjust the position. So this is my final set. Of course, I still flop over here, but this can be adjusted in my tilted implants. Good. So final part of our presentation, we'll see the zygomatic implant. Yeah. Okay, so again, the zygomatic implant is of, this is the armamentarium, the kit, my regular kit, and my zygomatic implants. So you can see the length, it's 40 millimeters, 47.5 millimeters. So tall implants to the core. They're the Badshaw of implants in India. So all my zygomatic implants are placed under local anesthesia, how it's a cord or a single zygoma, I don't care. And the flap raised, stands in position. So this is my guide drills. Okay, my guide drills, and here also you can see the apical push. You can see this is the drilling we do, the twist drills for zygomatic implant placement. So I can see I have kept my thumb on the outer part to see where I'm coming, okay, where the push is coming when I perforate the outer cortical. So I keep like that. So the moment it pushes, I stop. Yeah, you can see the last segment, you can see a small drop. That is my perfection of the outer cortical. Okay, that's how I decide, okay, my drilling is fine. Good. And then I measure and place the implant. So the cortical bone in zygoma is so dense. Now, if you don't keep my thumb over here, the implant will lift. Okay, so that much force will be generated, the heat will be generated in place of zygomatic implant. So it's important you do it very slowly with saline irrigation if necessary. Okay, and of course the torque is going to be 50 plus 60 plus. Good. So this is how we do again. Think of the 4-point cortical contact and the drilling protocols for zygomatic implants, which I showed you in the first lecture. Today we are not talking about the drilling protocols. I'm just showing you some cases where you use the TikTok protocols. So with the measurement gauge, we see the length and the implant placed. Okay, so this is the zygomatic implant placed. Good, beautiful at the crest, and then we use a 45-degree multi-unit usually. All right, and the right side, same thing. Okay, this is a zygomatic implant I use. This is Norris Medical with the polished collar, and apical will be 13 millimeters. This entire implant goes inside the dense cortical zygomatic bone. Imagine 13 millimeter of cortical contact. So this is my first primary contact. This is my second cortical contact. Very good primary stability and rehabilitation done using the nasalis, zygomatic, and pterygoid implant using the TikTok protocols. Good. So you can see a small offset over here. So you can see the change in angulation. So I have removed the multi-unit again and replaced it with the slight twist in the implant head to give me good parallelism. So this is this picture is a very special picture, and you can see here nasal implant engaging the nasal floor, the zygomatic implant. So we have the floor sinus, two entry into zygomatic bone, sorry, one crustal cortical, two the wall of sinus, three entry into cortical, four exit of cortical. So 4-point contact in the zygomatic bone. Pterygoid, we almost have 4 to 5 points of contact, of possible contacts for cortical bone. Nasal, again we have the crustal cortical and apical cortical, and here again we have the crustal cortical and apical cortical for the all on 4. So that is my rehabilitation. A very happy patient. We did finish this case in a month. Yeah, and this is again a CBC rendering of the case. So I have shown you 3 clinical scenarios of how we can use image loading using the TikTok protocols, right from single implant to segmental rehabilitation to full mouth rehab using nasal, pterygoid, and zygomatic implants. And I finish using my this quote. I'm proud to present in all my presentations, because I have come to this level of whatever I am, though I have a long way to go, because of this continued teaching we got engaged in. Because these things no one teaches in colleges. This is something we had to get trained, we had to find ways. And though 5-6 years back, I'm talking maybe 8 years back, there was very little scope of learning for these kind of techniques in India. But now we have done almost around 12 batches and trained more than 200 doctors in these advanced techniques using live surgery. And those days I had to travel abroad to get trained in these things. And that is exactly what got me back to my alumni at Ragas to show my guide. This is Dr. K.V. Arun. Yeah, and that is Dr. Veerabha over here, acclaimed surgeon. So about the drilling protocols of zygomatic implant, did a demo for them, a proud moment for me, because I kept myself engaged in continuous learning. So welcome to Chennai, where we have a beautiful training centers and my clinics, chain of clinics over there. And this is one batch of where we did live surgery workshop. This is my OT, is entirely stainless steel OT, where we do these live training equipped with relay and everything. You get patients coming, doctors coming from India and abroad for training. So you're all welcome to join me. So this is something surprise for all of you guys. I think Ruben will be talking about it, where you have designed exclusive because of the need from a lot of participants are asking for further training. Now it's been a lockdown period, and usually we keep ourselves engaged with learning and going to attend programs, courses in life surgery. Whereas now, I think till next Jan to Feb, difficult for us to conduct live surgery workshop. So I have sat with my team from DentistChannel.Online, my team from Implantology, and we have connected with doctors from India and abroad to conduct these two workshops. One is for basic implantology, which combines both conventional and single piece implant placement using cortical concepts. And the second workshop is again an advanced workshop on pterygoid, zygomatic, and all on four concepts. 2-day workshops with demonstrations, case demonstrations, model demonstrations, one-to-one interactions. So I think Ruben will be talking to you about that, and we'll be soon releasing the brochure with the faculty details and the curriculum details. So you can WhatsApp to us we'll give you the details. And I think I'm looking forward to this, because this is going to be my first time experience for me, also for our entire team, how we conduct a virtual workshop. And the advantage, now we can have international speakers right at our in our bedroom. I'm sitting in a bedroom and talking to you. So good. So thank you all. This is my number, my mail. You can always contact me with Insta or LinkedIn or WhatsApp. You can any kind of case discussions, any kind of technical info you need, suggestions on armamentarium, case planning. I can help you on that. So thank you all. I have finished my presentation in 40 minutes.
If we place tilted implants nearer to the root of the adjacent teeth, will there be a case of failure in implants?
Ruben, can you hear me?
Yes, sir.
See, that's why all these cases are done with CBCT planning, and sometimes they use guides also. We make sure that we do not touch the roots. We're at least 1 millimeter away from the roots. And if at all we touch the roots, the patient might develop some kind of sensitivity. And if you feel that the bone is so minimal that it has to touch at some point of time, okay, since the primary stability depends a lot on the apical cortical engagement, little brushing here and there will not matter actually clinically. And if the patient develops sensitivity, of course, we can do a root canal and work on that.
Thank you so much, sir. We move to the next question. According to a periodontist point of view, is basal implant more invasive than conventional? What is the future of basal implants? Is it basal or conventional as the future?
No, if you have to have a proper implant practice, I suggest you get trained in both conventional implantology and single piece implantology. I don't call it basal implantology. I call it single piece implantology, because you'll be able to manage all kinds of cases with these techniques. And that is exactly what we combine in our program. I do not shy away from basal implants, saying that it is wrong and prosthetically we have no solutions. There are specific indications for that. So that is to answer such questions precisely, we have this 2-day workshop where we focus on cortical implantology, both for conventional implants and single piece implants, and specific case indications, the drilling protocols, and how we can use both these techniques for managing all kinds of cases in your clinic.
Thank you so much, sir. We move to the next question. In lower molar region 6, how to perforate if it's near inferior alveolar nerve?
You don't have to. That's why I told you. The lower mandible, the entire lower border is basal bone. So you'll be actually engaging basal bone even if you go for maybe 10 to 11.5 millimeters. So you do not have to perforate at the lower border. I mentioned this very clearly in the presentation.
Thank you so much, sir. We move to the next question. What should we keep in mind while virtually placing the pterygomaxillary implant in CBCT planning?
No, that's a pterygoid lecture, not the scope of this lecture. And this pterygoid lecture by itself will go for 2 hours. I don't know if I can, because there's a lot of things to be done, right from the mesiobuccal angulation to the palatal tilt to the length we use, because there are at least 5 different positions a pterygoid implant can engage. Tuberosity, pterygotuberoid, tuberopterygoid, tuberopalatine. So it's a big question. Maybe maybe try to connect to me personally. I'll try to help you out. Or maybe if you search for my pterygoid lectures on YouTube, it is there. You can listen to that, or you can join us for our program.
Thank you so much. So, next question. What is Dr. Johnson's take on traditional implantology? Does he practice cortical implantology alone or does traditional implants as well? We all learned about the pros of TikTok. What about the cons? Any failures or complications he would like to share?
See, because all these implants are engaging the apical cortical, so you have to be very careful when you drill the past the apical cortical bone. Because imagine you are drilling the nasal floor. If your drill passes through, you will sometimes damage the nasal mucous membrane and it can lead to bleeding. Patient might be very apprehensive. There's a bleeding happening over here. So those are the only things which you have to be careful about when drilling into zygomatic bone, pterygoid plate, drill past the apical cortical plate. Drill should not slip. That is the only thing you have to be very careful about. And what I'm trying to tell you is traditional implantology also is now modified to engage the apical cortical using the TikTok protocols. See, right from Brain and Mark, a lot of doctors who did their research on zygomatic to early osseointegration, they use long implants. Over a period of time, I don't know how it changed this concept of using short implants of 10 to it's all changed right now. But then the longer implants you use to engage apical cortical, the better success rate you're going to have.
Thank you so much. So, next question. Can we place a tilted implant near to a root canal treated tooth?
You can, but not make sure your threads do not give any pressure on that tooth, because even if root canal treated, when your ligament brain ligament fibers are under compression, they're going to cause some kind of pain. So you will have to keep your it's a limitation, your runtime limitation. You have to keep your implant at least 1 to 1.5 millimeter away from the root.
Thank you so much. So, last question, and I think once again a beautiful question, controversial question. Which material is the most suitable for implant?
Grade 5 titanium, nothing more. I do not use polished surface, it's all rough surface, and grade 5 titanium. And make sure the implant you buy is grade 5 titanium. Now, a lot of implants come to market which claim to be this and that, but they're hardly titanium grade 5. So, grade 5 titanium is the best metal you can have for implants. Ceramic implants, I have no experience, so I can't comment much.